Okay, imagine this. You're on the floor, your patient's monitor starts beeping, and you see their O2 sets dropping. What's your first move? If you're prepping for the NCLEX or ETI, you already know questions about hypoxia and oxygen devices are a huge deal. Well, in this explainer, we're going to make sure you have the confidence to nail those questions every single time. Let's dive in. So, before we can fix the problem, we've got to understand it. And it all starts right here with hypoxemia. It's just a clinical way of saying there's not enough oxygen in the arterial blood. Now, for your exams, you absolutely have to know this number, a PO2 of less than 80. PO2, of course, is the partial pressure of oxygen in that arterial blood, and it's a huge indicator of how well your patient is oxygenating. When it dips below 80, yeah, that's when the alarm bells really should be going off in your head. I want you to think of hypoxemia as the very first domino to fall, because when it goes down, it kicks off a chain reaction that leads straight to hypoxia, which is low oxygen in the body's tissues. And that, my friends, is where things get really, really dangerous. I mean, just picture it. Your brain, your heart, all of your vital organs are just gasping for air. That's literally what's happening when a patient is hypoxic, and it's exactly why we have to act, and act fast. All right, so here's our game plan. We are going to become masters of hypoxia. First, we'll nail down that domino effect we just talked about. Then, we'll become detectives and learn how to spot the early warning signs before things get critical. After that, we'll open up our toolkit of oxygen devices and figure out how to pick the right one for the job. And to wrap it all up, we'll put it all to the test with a real ATI-style question. You ready? Let's do this. Okay, so if you remember just one thing from this first part, make it this. Low oxygen in the blood leads to low oxygen in the tissues. Say it with me in your head. Low blood oxygen equals low tissue oxygen. This is the fundamental problem that we as nurses are always working to prevent or fix. So how do we catch this whole domino effect before it completely spirals out of control? Well, we put on our detective hats and we start looking for clues. And let me tell you, the NCLEX and ATI absolutely love to test your detective skills on these early signs of hypoxia. And you know why? Because in the real world, catching this stuff early can literally be the difference between life and death. You know, the brain is an incredibly greedy organ when it comes to oxygen. So when it's not getting enough, it is one of the very first parts of the body to complain. So if your patient suddenly gets restless or agitated or confused, don't just write them off as being difficult. This could be a massive red flag that their brain is starving for oxygen. So a sudden change in mental status, your first thought should always be, could this be hypoxia? Next up on our list of clues, the vital signs. See, your patient's body is smart. It knows something is wrong, and it's going to try to fight back. And how does it do that? It kicks everything into overdrive. Their breathing will get faster. That's tachypnea, trying to suck in more oxygen. Their heart's going to beat faster, tachycardia, to try and pump that oxygen-poor blood around the body quicker. And their blood pressure is going to go up, hypertension. So just remember, in the early stages of hypoxia, everything is high, high, high. You know, sometimes the clues are written all over your patient's body. I mean, you can literally see them struggling to breathe. You'll want to look for the muscles in their neck and chest straining with every single breath. That's a classic sign of increased work of breathing. You might also see them leaning forward, propping themselves up on their arms. We call that tripoding, and it's their body's way of trying to open up the lungs to get more air in. These are textbook signs of respiratory distress, and you just can't afford to miss them. Now, you might be thinking, whoa, that is a lot to remember. But trust me, it is so worth it. These early signs are an absolute goldmine for NCLEX and ATI questions, especially those really tricky select all that apply ones. So please burn this into your brain. In early hypoxia, the body is in overdrive, desperately trying to make up for that lack of O2. All right, we've cracked the case. We know what early hypoxia looks like. Now it's time to spring into action. So let's gear up and explore the different oxygen delivery devices that are going to help us save the day. And first up, we have the trusty nasal cannula. You are going to see this little guy everywhere in the hospital. Seriously, I remember my first clinical rotation, I felt like I was putting nasal cannulas on pretty much everyone. It's the absolute workhorse of oxygen delivery, and it's perfect for patients who just need a little bit of low-flow oxygen. Okay, let's talk numbers. A nasal cannula can deliver anywhere from 1 to 6 liters of oxygen per minute. That gives you an O2 concentration of about 25 to 45%. It's a fantastic option for short-term use, like right after surgery. But what if your patient needs it for a while? Well, that dry oxygen can get really rough on their nose. So what do? We add some humidification, just a little moisture to make it more comfortable. But what happens when that nasal cannula just isn't cutting it anymore? Well, we need to bring in some bigger guns. Okay, not the biggest guns, but definitely the next step up, the simple face mask. So as you can see, the simple face mask covers both the nose and the mouth, which lets us crank up the oxygen a little bit more. Now we're talking 6 to 10 liters per minute, which gives us an oxygen concentration around 40 to 60%. It's a really solid choice for when your patient just needs a bit more of a boost than a nasal cannula can provide. All right, now it's time to bring out the real big guns, the rebreather masks. They might look super similar, but trust me, there is a crucial difference between them. A partial rebreather actually lets a tiny bit of exhaled air back into the reservoir bag. But the non-rebreather, or the NRB, has these clever little flutter valves that act like one-way doors. They let exhaled air out, but they slam shut to keep any room air from getting in. This simple little feature means the NRB can deliver the highest possible concentration of oxygen. So yeah, the NRB is not for your everyday, stable patient. This is for the life-or-death emergencies. Think things like carbon monoxide poisoning, a severe asthma attack, basically any time your patient is in major respiratory distress. And when you're using an NRB, there is one thing you absolutely positively have to watch like a hawk, that little reservoir bag. If that bag completely deflates when your patient breathes in, that is a 5-alarm fire. It means they are not getting enough oxygen and you have to crank up that flow rate stat. Okay, listen up, because this right here is a classic NCLEX trap. I promise you'll see it. They'll give you a scenario, a patient with an NRB mask, and that bag is deflating with every breath. Then they'll give you a bunch of options like tighten the mask or open the flutter valves. Do not even think about it. Those are just distractors. They're there to trick you. The first, best, and only correct answer is to crank up that oxygen flow. Don't let them fool you. So, we've got our toolbox full of all these awesome oxygen devices. But now comes the real art of nursing, right? How do we know which one to use for which patient? It's kind of like a puzzle. We have to look at our patient, assess their specific needs, and then pick the absolute perfect tool for the job. So let's talk about a tricky situation. What if your patient has facial trauma or, say, burns on their face? You can't just slap a regular mask on them, right? That's where the face tent comes in handy. It's this loose-fitting device that delivers high-humidity oxygen without actually having to touch their face. And here is a super simple trick to remember it. F is for face tent, and F is for face trauma. Easy, right? Next up, we have what I like to call the sniper rifle of oxygen delivery, the Venturi mask. Its superpower is its incredible precision. It can deliver an exact, pinpoint-accurate concentration of oxygen. And that's an absolute game changer for a very specific group of patients, those with unstable COPD. So why is this precision so ridiculously important for our COPD patients? Well, for them, too much oxygen can actually be a really bad thing. It can literally knock out their natural drive to breathe. So we have to be like Goldilocks and find the amount of oxygen that is just right. And the Venturi mask is pretty much the only tool that can give us that level of control. So remember, V is for Venturi, and V is for very accurate oxygen delivery. Okay, deep breath. We have been through a lot. We've talked about the problem, the clues, the tools, the whole strategy. But now, it is the moment of truth. It's time to put all that new knowledge to the test and see if you've really got what it takes to ace the NCLEX. Okay, here we go. This is a real question straight from ATI. Which of the following are early indications that a client is developing hypoxemia? Select all that apply. I'm going to give you a few seconds to think about it. Ready? Go. And the correct answers are restlessness, confusion, hypertension, and tachypnea. How'd you do? If you got them all, seriously, congratulations. You are well on your way to being a hypoxia expert. And hey, if you picked bradycardia, don't worry about it. It's a super common mistake. But now you know, a slow heart rate, that's a late sign, a very, very bad sign. It means your patient's body is exhausted and it's starting to give up. So remember the